All right, we'll go ahead and get started. Once again, I'd like to welcome everybody who's just getting settled. My name is Leanne Foster, and I am a provider outreach and education specialist here at WPS. I want to thank you all for taking the time to join us today, and I hope you're doing well. So today, this session is our E&M training camp for nursing facility services. This is a two-part session. Today's session is going to provide you with the core knowledge for E&M services that are provided in a nursing facility setting. Tomorrow, Ashley's going to be offering an interactive session. It's a Q&A session that's going to talk about denials and rejections and how to avoid those. But also, I mentioned it's an interactive session. She's going to provide you with an opportunity to apply your knowledge from today's session. She'll do a recap, and then we will have, again, those interactive activities that are going to help you apply that knowledge. So if you've not yet registered for her session tomorrow, that registration is still open. So I would encourage you to consider registering for that. So for today, this is training camp, and we're going to talk about nursing facility services. And we're going to cover E&M services for patients in nursing facilities and skilled nursing facilities. This is not the same as billing for skilled nursing facilities, and I call that out because a skilled nursing facility stay is a Part A stay, and you run into all sorts of things about consolidated billing, how to bill, chronological billing, and that is actually multiple sessions in and of themselves. And we do actually have a playlist on our YouTube channel if that's something that you're interested. The focus for today are going to be services that can be performed in that nursing facility, but not necessarily part of that Part A stay. These are services that can be performed by the admitting provider. It can also be other providers that are providing maybe specialty care or concurrent care to the patient in either a skilled nursing facility or a nursing facility stay. Our goal today is for you to better understand the requirements for providing E&M services to patients in that nursing facility or skilled nursing facility setting. And we want you to better understand the difference between a skilled nursing facility and nursing facility requirements. So in order to do this, we're going to talk about a few things. We're going to talk about the difference between nursing facility and skilled nursing facilities. We're going to talk about the billing requirements for nursing services, for E&M nursing services, including federally mandated visits. We're also going to talk about certifications, recertifications, and the assessments that need to occur in these services. As with pretty much every other facet of our lives, there are going to be acronyms that I use today. And I often say that Medicare could use a Medicare to English dictionary. So for the purpose of today's session, I have included an acronym slide that's going to include those acronyms that I'll be using throughout today. So this will be your Medicare to English dictionary for today's session. So we're going to start with our overview of nursing facility services. So first and foremost is medical necessity. Medical necessity is the first determinant of coverage for any service that's reimbursed by Medicare. So per the Social Security Act of 1935, Section 1862, which I have included a link to if you'd like to take a further look at that, services must be reasonable and necessary to treat an illness or injury or to improve the functioning of a malformed body member. These services if you're going to bill Medicare, they do need to be medically necessary, or we're simply not going to reimburse those services. And this is all going to be based on your documentation. In all of our sessions, all of our education, we talk a lot about documentation, and that really is the provider's proof of thought. So what are we looking for medical necessity? So what you want to ask yourself is, and what we need to be able to see if we're reviewing that documentation, because remember that documentation doesn't come in with the claim. It's something that if that claim is pulled for review, a medical reviewer is going to need to see these elements in that documentation. So the documentation needs to clearly state, what are you doing for that patient? Is it clear in that documentation? Why does the patient need your services for this encounter? This is going to be these are going to be the questions that those reviewers are asking. And that's not just our MAC medical review area, but this is also going to be for any reviewers from the Comprehensive Error Rate Testing Contractor, or CERT. So that's the first thing they're going to look at. And then they're going to use that to determine, is the service medically necessary for the patient? It all comes down to that documentation, that proof of thought. We're certainly not going to ask the providers to write a novel, but we just need to make it clear what is being done for that patient and how that is medically necessary for that patient. So now getting into nursing facility services, I want to spend a little time going over that difference between a skilled nursing facility and a nursing facility. We actually received a pre-submitted question related to this, asking how to determine which place of service to use or how to identify whether or not it's a skilled nursing or a SNF or a nursing facility. So for a SNF, we'll start there. Their place of service is going to be 31. And if you're using place of service 31, it means that that service is part of a Part A payable stay. That is going to be that facility service. So that Part A payable stay means Medicare is paying not only for the services that the patient receives in that skilled nursing facility, but we're paying them at the facility rate. So we're paying for that stay, that room and board at that point, because it's part of that. You'll know if they are in a Part A stay. Ask yourself how you're billing for those services. If you're billing on that UB04 or 837I electronic transaction, that's going to be something that's going to be a Part A payable stay. Now, you also do need to make sure of that beneficiary's status. So that Part A payable stay versus a Part B stay, it is based on the status of that patient and not necessarily their physical location. We have situations where we have nursing facilities or even hospital units that are what we refer to as a swing bed. And they can switch between the type of stay. They can go from a hospital stay or a nursing facility stay to a skilled nursing facility stay without the beneficiary having moved. So make sure that you're checking that beneficiary's status, because it's not just about where that patient is physically located. With a Part A payable stay, with a skilled nursing facility stay, Medicare will pay for 100 days of that stay, and this is referred to as a benefit period. What happens after that 100 days, if they are when they're no longer in a Part A payable stay, they'll still be in the facility, but at this point they are moving to a nursing facility stay, which is a Part B stay. So a nursing facility stay is going to be that place of service 32. And they are getting paid, but they're getting reimbursed at the non-facility rate. So now we're still paying for all of the professional services that are being done for that patient, but we're not paying for that facility piece, for that room and board piece. The other thing to look at here is, how's that stay going to be billed? I mentioned the UB04. If it's being billed on a CMS 1500 or an 837P electronic transaction, that's going to be that Part B stay. And again, that stay is based on that patient's status, not just where they're physically located. So that is one thing you need to keep in mind when you're looking at these. However, today we're talking about E&M services that are being billed in either scenario and what we're looking for. So next, we do want to talk about certifications and recertifications. So a physician must personally approve in writing a patient's admission to the facility. This is often obviously happening prior to that admission. It's either happening at the time of admission or very soon thereafter. And that soon thereafter is not a very definitive statement, but that is how CMS outlines this in the IOM and in their manuals. So that needs to happen really pretty close to the time they enter that facility. So per CFR 42 CFR 483.30, the orders for immediate needs can be by the physician assistant, the nurse practitioner, or clinical nurse specialist. And this also can be the hospitalist, the surgeon, or someone attached to the facility. I have included, we're not spending a lot of time on that CFR today, but I have included a link to that in the resource section if you would like more information about who's writing that. So subsequent recertifications need to happen no later than the 14th day after admission. So that recertification happens pretty quickly. After that, it does need to happen every 30 days. It definitely cannot exceed those 30 days. And what we're looking for is that we need to recertify that they need this care, that they still need to be in the nursing facility, in the skilled nursing facility. Now, these certifications and recertifications, typically the facility, so the nursing facility, the SNF, they're going to be the ones that are going to retain these in the patient's medical record. But if you're providing the E&M services in these facilities, you're going to want to make sure that you are going to be able to access them if Medicare requests it. There may be times that we're asking for documentation, and we're going to be looking for these as well. What happens if we don't get these certifications, it could impact your claims. So say a physician or a PA or an MP or a CNS refuses to certify or recertify, the facility cannot bill to Medicare and they cannot bill that patient. So these certifications and recertifications are really pretty important because they are certifications that are stating that that patient needs that care. If they're not there, then the reviewers are going to look at that as the patient may not need that care. So it's important to make sure that these are in place and that you have access to those. Now, one thing I do want to call out with these, Medicare does not have a template and they don't require a specific form or format for these. It can simply be part of the medical record. However, what we found when we see these come in for review, we do find that sometimes the facilities do have some type of a template, but that's going to be a conversation you'll need to have with the facilities. One, to make sure that they have them, and again, two, to make sure that you have access to them. So here are some specifics about what needs to happen and what needs to be included in these. So it needs to contain why that patient needs that skilled service. So why are they there? Why are they not able to go back to their residence or their community setting? What is the need for that care? We need to know what services that they're receiving, what are the skilled services that they're receiving, and then we also need to know what the expected length of the stay is. Now, keep in mind this isn't an exact science. So, for example, there could be a certification in place that says the patient needs 90 days of facility care. Maybe in the end they only need 60. That is okay. Again, those certifications need to be in place, but in the example that I just gave, that 90 days, that is the expectation of what they're going to need. But again, we can't predict the future with absolute certainty, but that's also the reason for the recertifications, because they can document those changes. You know, it can happen where that patient maybe doesn't respond and maybe that stay needs to be extended. It could be the patient responds very quickly and they need less time in that skilled facility. So they also need to have the practitioner's name and signature. That's going to be the practitioner and signature of the individual that is doing that certification or that recertification. Generally, that's going to be the MD, the DO. It could be a PA, it could be an MP, or it could be a CNS. They can all provide those. Sorry, I'm just having a little trouble getting my slide to move forward. My apologies. So after certifications, the next thing I want to talk about is going to be the comprehensive assessment. So the comprehensive assessment is not the same thing as that initial order for those nursing facility services or SNF services. It's also not the certification or the recertification. This is a different thing. This is a comprehensive assessment of the patient, and this is being used to verify the order and the patient's need. So the SNF In a SNF, only the physician can provide that. An MPP, so those PAs, those MPs, those CNSs cannot provide this. Now, there's going to be times where maybe they are seeing the patient for some other medically necessary reason before this comprehensive assessment happens. That is okay, but that comprehensive assessment in a SNF needs to be the physician. Now, in the nursing facility, it's a little bit different. In a nursing facility, and again, we're looking at the status of that patient when this happens. In a nursing facility, this can be the MD or DO, but it could also be a non-physician practitioner as long as they are not employed by that facility. And by employed, I mean directly or indirectly. So directly is going to be they're a W-2 employee, they directly work for that facility. Indirect could be there's some type of contracted staff. They could be leased staff. They don't necessarily work directly for that SNF, but they have been contracted or hired to provide services. So just keep that in mind. If that non-physician practitioner is directly employed by the facility, they're not going to be the ones to provide that. So if this is being completed by the principal physician of record, that's typically the one that's going to be performing that assessment. They're going to apply a modifier AI, and that's an informational modifier that just lets us know who that principal or that attending physician is for that patient in that facility. Okay. The other thing that's super important with this is that this comprehensive assessment does need to happen no later than 30 days from the date of admission. Okay, so this has to happen, not immediately as they get checked in, but there needs to be that comprehensive assessment within those 30 days. So some additional details about that comprehensive assessment. Again, for a SNF, it's got to be that physician, and they're completing the assessment. Part of that is that they're developing that plan of care, and they're writing and verifying the admitting orders. They're making sure that, yep, this is what's happening. There may be some adjustments as part of that, but that's their starting point, and now they're taking on that patient's care. And as I said, it has to happen within 30 days. Documentation is going to have to show that this is that comprehensive assessment. So when we look at it, we want to see that this service happened and it is that comprehensive assessment. This can be billed as an initial visit. This very well may be the patient's initial visit with that provider, but they can only bill that initial visit if it's the first time they have seen the patient. We'll talk about that a little bit more. We do run into scenarios where perhaps the provider saw the patient in the hospital and now they're seeing them in the SNF or the nursing facility on the same day. You're not going to bill for two initials. What you're going to do is you're going to take the services from the hospital, include all of that into the services, and you're going to bill that initial nursing facility or skilled nursing facility visit. We also want to talk about federally mandated visits. So what does that mean? So a federally mandated visit is something that is Congress mandated through the Social Security Act. And again, I've provided you with those links. That's actually part of that Social Security Act that I gave you. But these are visits that are mandated by Congress where they mandate that patients within skilled nursing facilities and nursing facilities must be seen on a regular basis. That's the distilled version of what that says. So here you can see those time frames. This is something that's going to happen if it's in the SNF. It's going to be after that initial comprehensive assessment, and they are going to happen in a SNF or a nursing facility. They are going to happen every 30 days for the first 90 days and every 60 days thereafter. But in a SNF, you can alternate these visits with the nurse practitioner after that initial comprehensive visit. So the physician would do the first federally mandated visit and then they can alternate with that nurse practitioner as they deem necessary. In a SNF, that non-physician, shouldn't say not just nurse practitioner, but that non-physician practitioner can provide that initial one. So it's just a little bit different. But with all of these, you want to call out in the medical record that this is a federally mandated visit. Okay. You can also combine these with a regular visit. So an example, you have a federally mandated visit and then you have a visit the next day for a medically necessary service. They don't have to be on two separate days. If you're going to see your patient for a medically necessary visit or a medically necessary service, you can combine that with that federally mandated visit. Just make sure that you're calling that out. Um, that federally mandated visit, there should be some medical necessity to that as well. But so we're going to ask questions if you're doing them back to back like that and one maybe doesn't have any medical necessity, because chances are you go for that federally mandated visit, you're also potentially doing other services if you already had other services planned for that patient. The other thing that I want to call out about these is federally mandated visits, they have to be provided face to face. So these are going to be in person. These are not something that can happen through telehealth. Again, what Congress is mandating is that the provider is going to see that patient on a regular basis and assessing their needs and providing those services. So just make sure that you're aware that's not a telehealth service. So next we're going to get into billing requirements for these services. So for E&M services that are occurring in a nursing facility, much like office and other outpatient services, you can choose your level of service either by using time or MDM, or that medical decision making. You want to make sure that you are choosing the one that is most advantageous to you. You did the work and Medicare wants you to get paid for your service. So don't sell yourself short. Make sure that you're looking at both, assessing both, and billing the one that makes the most sense. Uh, we get the question of, should I always choose MDM? Should I always use time? Or can I switch back and forth depending on the patient and their needs? So this is really up to your office. The answer is all of those work. You could decide that you have a practice standard that we always use time because of the types of services that we provide, or that we always use MDM, like I said, or you can pick and choose based on the situation and that encounter for that patient. That is not something that is you have to have set in stone, but it is something that you're going to have to decide. If you're using time, make sure that you are including both face-to-face and non-face-to-face time for qualifying activities. Now, we're not going to spend a lot of time here on level of service. We do have a webinar that we did in May that is now available on our YouTube channel for level of service. And Ashley's just put our playlist, or our playlist, in the chat. You'll be able to find it through our encores. But face-to-face time is obviously time on that date of service with the patient. You're actually with that patient. The non-face-to-face services, there are qualifying activities. This can include things like reviewing test results, because you're preparing for that visit. It could be time spent after that visit coordinating referrals or different types of care, different interventions. So make sure that you're counting all of that. One thing you're not going to count is going to be travel time, but again, make sure you're not missing anything. You did the work. We want you to get reimbursed. If you're billing by time, you are also eligible to potentially bill for prolonged care if it makes sense for the service, if you've gone above and beyond the highest level for level of service for that particular procedure code based on time. Those prolonged services are based on time only. For MDM, it is problem, data, and risk. So the problem is, what are you addressing for that patient on that date of encounter? And I just want to call out, this may is not necessarily driven by diagnosis. You do need to document in your medical record, in your documentation, what you're doing for that patient. But I also want, or what the problems are for that patient, but I also want to call out that it's not necessarily going to be every diagnosis or every condition the patient has on that date. We often get questions about patients, they have 25 different diagnoses. Do I need to put those all on every claim? No. List the diagnosis codes or list the problems that you're dealing with today. Maybe you're dealing with they had hip surgery and that's what you're working with today. They may also have high blood pressure, high cholesterol, and diabetes. If you're not addressing those three, the high cholesterol, the blood pressure, and the diabetes, they don't necessarily need to be part of the problem list. But if you are, because they're impacted by what you're doing for that patient for that hip surgery, then you could list them. Now, data is going to be the tests, the unique resources, and the conversations that you're using to assess the patient and make their plan of care. And then that risk is going to be the risk to the patient from the medical decisions that you're making that day. Regardless of which you choose, as I've said a couple of times, documentation does need to support that level of service when it's reviewed. Now, with initial nursing care E&M services, the CPT, the AMA CPT does outline one additional criteria for a high problem level. It's not in the chart if you're looking at the CPT, it's in the nursing facility section of CPT. So I just want to make sure that I'm calling that out. This is going to be when the patient has multiple morbidities that are requiring intensive management, or a set of conditions, syndromes, or functional impairments that are likely to require frequent medication changes or other treatment changes. They could require frequent reevaluation. So basically, this is something that puts the patient at significant risk of worsening medical, which does include behavioral health, status, and risk for readmission to that hospital. So the idea is we want to make sure that we're keeping the patients from rehospitalization, right? So with nursing facilities services, CPT has outlined another scenario in which high risk may apply. But again, your documentation does need to support that. So what we're looking for to support that's going to be clear documentation on what's going on with the patient. So what are the morbidities? What are the conditions that are requiring that intensive management? Why are you needing to manage them a little bit more closely? We need to know what medications might need to be changed frequently. It could be this is simply how that morbidity or condition is treated. It could be that the patient's having reactions to medications. It's going to be unique to that patient. You also want to make sure that it's clear what the treatment change possibilities are based off of those reevaluations. And then we also want to know what that patient's significant risk for that worsening medical or behavioral health status or that hospital readmission are. So you just want to clearly document why this patient is at that high problem level, why they're at that higher risk. The other thing, especially when we are talking about the procedure codes coming up, we'll talk about initial and subsequent codes in a few minutes. We do need to, oh, I apologize. There we go. I went too far forward. I want to make sure that we talk a minute about same physician. So same physician is pretty easy. So basically you can't bill the same physician in the same group with the same specialty cannot bill for an initial visit. So this is the definition of an established patient. But I want to talk about these criteria for a second. So same provider, an example would be the practitioner is Dr. Smith. If that same provider saw the patient within the previous 3 years, that is the same provider. We get questions about providers moving from one tax ID to another. Same provider is driven by MPI. So if you have a provider who's maybe moved from facility to facility, and that does happen for varying reasons, they're not an initial patient every time they see them. If they've seen them in the last 3 years, they're still established. So keep that in mind. If they saw the patient in their office or inpatient care, your nursing home or your skilled nursing home visit would still be a subsequent. Same group is defined by tax ID. Same specialty, that's going to be based on the two-digit specialty under which that practitioner enrolls. So when providers enroll in Medicare, they do need to select a specialty, and it's a two-digit code. That is what claims are adjudicated off of. So for example, a cardiologist and a family practice physician, they are different specialties. A physician and a non-physician are different specialties. A physicians can pick their area of focus, so say cardiology or family practice or podiatry, rheumatology, what have you. Non-physicians cannot do that. Non-physicians are that non-physician specialty. So an NP is an NP regardless of their scope of practice. A PA is a PA regardless of their scope of practice. Again, not making light of the services those providers provide, but from a two-digit specialty code perspective, they are the same. It's important to keep that in mind, especially if you have non-physicians, PAs and NPs that are billing inside of various scopes of practice. When the claim comes in, they're going to look the same. So it's important. Ashley just did a webinar on non-physicians billing for a scope of practice or a little bit of a different specialty than just what they're enrolled as. You can do that, but you have to call out. Say you have a cardiologist or cardiology nurse practitioner, and you have a nurse practitioner that is practicing in rheumatology. Want to make sure you're calling out that cardiology and rheumatology in box 19 of that and coordinating loop that CMS 1500 or 837P transaction. Just make sure those claims go through. So we want to talk a little bit also about procedures on the same day. And the reason we talked about same physician is because when there are multiple E&M services on the same day, we need to know whether or not they're going to be billed as one or if they can be billed separately. So E&M is a per diem service. So it's going to be reimbursed once per day. So as I mentioned, if you see the patient in the hospital and you also see him in the nursing facility or skilled nursing facility, you're going to combine all of that MDM or all of that time, and you're going to bill it on the nursing facility. That's going to be your highest level of visit that day. So what Medicare says about multiple services on the same day is that to be reimbursable, they have to be unrelated or could not have happened at the same time. So unrelated, that's going to be you've got a patient who went for hip surgery and let's say now they have a sinus infection. Those are unrelated. That's something that you would be able to bill separately. Now, if the patient is in the facility following a surgery, maybe they had a hip replacement, the E&M is reimbursed as part of that surgical code if there's a global surgery period. So that's another thing to look out for. That happens quite often. So they're not going to bill for a separate E&M inside that global surgery period. But there are times where those E&M services provided in the nursing facility may be separately billable. The first one is going to be modifier 25. This is going to be where it is significant and separately identifiable. So this could be that not related diagnosis code. You're still going to want that modifier 25 on there because that diagnosis code is not going to be enough. We're also looking at significant. That significant is going to be that you're telling us that E&M service was a great amount of additional work than what is considered typical for the service provided. So if you're doing it in addition to a surgical procedure, it has to be something that is above and beyond what typically happens in that global period or for that procedure. And the documentation does need to support that modifier 25. It's not something that you're going to put on every E&M. It does have to be backed up with that documentation. Now, we're not spending a lot of time on this one, but I do want to encourage you. In December, I will be co-hosting a webinar with a member of our clinical staff on December 18th, and that registration is now open. We're going to go more in depth into the use of modifier 25, but in addition, because we have clinical staff, she is going to be going through documentation examples of good and bad documentation for what is significant, what is separately identifiable. So if you're interested in that, that registration is available on our live events page. So the next modifier that could happen if you have multiple procedures on the same day is modifier 24. So this is going to be used when the E&M service that's provided is completely unrelated to the surgery with that global surgery. So it's completely unrelated to them. That global surgery period is going to be something that has a global surgery of 10 or 90, minor or major surgery. Also have to ask yourself, are you the surgeon? If you are that surgeon, like I said, that E&M is going to be part of that global period. So 24 is just telling us that the service is completely unrelated to the surgery, and you just need to ask yourself that. And again, that documentation has to support. So pretty straightforward there. And typically that modifier 24, it's not going to be on the same day. That 25 is going to be the one that you're going to do if it's on the same day. But during that global period, that 24 is still going to be a thing. The other one that I have listed here is modifier 57, and this is not really all that common, but we do see them. This is going to be used by a surgeon when when they're performing the decision for the surgery, say today or tomorrow. Basically, you have to have your surgery now. This is not going to be an example of where a month ago you and the patient decided that we need to move forward with a hip replacement, and now you're seeing them the day before the surgery, probably for a pre-op. That's not that modifier 57. That is not the decision for surgery because that was made a month ago. So that's something to keep in mind. This is going to be urgent surgeries that are like literally happening in the next day or so. And again, this is not terribly common. So Medicare does allow for multiple physicians in certain cases. We do find this happens with your nursing facility patients. So typically, when this is allowed, the physicians are not the same physician as defined by Medicare. But what can happen is you have multiple physicians and they're treating different diagnoses. So say you have their attending physicians coming in, but then they also have maybe a podiatrist that's coming in because they have an unrelated condition, or they're doing their check from the patient has diabetes, and so they're doing a foot check, that kind of a thing. That's going to be something that's unrelated. It could also be that you have multiple physicians and the documentation supports the medical necessity of each visit. So most of the time, these are, again, different specialties, and that's that 2-digit code. If your service qualifies for the different diagnosis or your documentation is supporting that, when you bill for those services, Medicare processes based off of, as I said, the 2-digit specialty code, and we don't process off of taxonomy. So if you have services that are supported by documentation that can be billed on the same day for different reasons because of that specialty, if it's the same, they're going to deny. If the specialty is different, they're going to process just fine. If your service qualifies for the different diagnosis and the documentation, but they're the same specialty, it's going to deny, and you are going to have to appeal that with documentation that's supporting how you're meeting those two exceptions and why that service should be paid. So make sure that you're specific as to why that meets those exceptions and can be paid. And this does apply to both initial and subsequent visits, and we'll talk about that in a minute. We talked about this a little bit already, but I want to talk about all of the place of service codes that could be used to bill E&M services in nursing facilities or SNFs. So first we talked about 31. That's going to be your SNF. That's that Part A qualifying stay where you're actually getting reimbursement for at that facility rate. 32 is going to be the nursing facility. This is going to be that Part B stay. So we're no longer paying at the facility rate, but we are still paying for professional services. Other way is, how are you billing this? That 31, typically SNF services are, the facility services are being billed on that UB04, the 837I, and then those professional services or Part B covered stay are going to be under that 1500 or 837P, but again, based on patient status. You could also have situations where these services are going to be billed under Place of Service 54, which is an intermediate care facility that could be like a group home or a facility for individuals with intellectual disabilities. So that is something that is a place of service that may be used with the codes we're about to talk about. Place of Place of Service 56 is a psychiatric residential treatment center. So those are also it's another place of service that's eligible for these codes. And again, here I am just reiterating what we talked about earlier as far as determining that place of service, patient status versus where they physically are. It's that Part A covered stay versus a Part B. This is specific to 31 and 32. 54 and 56 are pretty straightforward, but 31 and 32 are one that I am harping on just a little bit because that is one that we get a lot of questions about, and there seems to be a lot of confusions about that. But I also want to make it clear that you could have facilities that have both skilled and non-skilled beds. And like I said earlier, they can switch back and forth. So when you're seeing patients in nursing facilities, it is super important that you're asking the facility about the patient's status. There could be situations where your service needs to be part of that skilled nursing facility billing under consolidated billing. Again, I mentioned we do have a lot of education and videos regarding that. We're not going into that, but we do have that available if you have that. But that's an important piece of this, is knowing what your patient's status is, especially if you're going into these facilities. It's not going to necessarily just be apparent. All right, so the codes that you're going to be using. So the initial codes are used for the first time the practitioner or member of that same group with that same specialty are seeing the patient in the facility. Okay, so again, we talked about that situation where you saw the patient in the hospital and you're following to the skilled nursing facility. That's all going to roll up. This is a little bit different situation. This is, you didn't see them prior, you're seeing them for the first time in that facility. You're going to use codes 99304 through 99306, and then you're going to choose your level of service, either off of medical decision making or time. Again, as a reminder, if you are billing for the principal as the principal physician of record, or what Medicare will consider that admitting physician, make sure that you're applying that modifier AI. Again, this is an informational modifier, but it's important that it is there because other providers may bill for an initial visit, and we're just going to need to know which one's the admitting or principal physician versus other physicians providing services. Now you can see here, this may be the admitting physician or it may be other. Like I said, you're going to have specialties coming in that are providing maybe consults, and we'll talk about that in a minute, but they're providing those services. Those physicians that are not that admitting physician, they are not going to include that AI. So make sure that that's not just going through on all of your claims. It's got to be very specific. And then it can also be nurse practitioners, or excuse me, non-physician practitioners that are providing other medically necessary services as long as that documentation supports. The other thing that I do want to call out, and we get this question, status. It does not change whether or not a patient is going to receive or whether you're going to bill for an initial or a subsequent stay. What I mean by that is if they started out your initial visit, they were a SNF or skilled nursing facility patient, they have now been reclassified to a nursing facility. The first time you see them under that nursing facility status does not mean you can now bill for an initial visit. It's still a subsequent. So let's talk about those codes. Subsequents are any other services that are provided after the initial visit. So those initial codes, you're going to bill once, and everything after that's going to be those subsequent care codes. This can again be that admitting physician, or it can be any other provider that is providing medically necessary services. Um, the codes you're going to be using are going to be 99307 through 99310. They the services do need to stand alone if you're billing for multiple of these. They need to stand alone, and the services do need to be medically necessary. Something that we do see, and I do want to call out, is a physician that is maybe going and seeing the patients every couple of days, every week. It's not a federally mandated visit, and they're not actually providing services. Those are not billable visits. Got to make sure that there's a medically necessary reason in order to bill that to Medicare. For prolonged care services, this is going to be only if you're using time to choose your level of service, and you need to meet the threshold time for the highest level of service for either your initial or your subsequent visit codes. So here I have included the chart. So with CMS, you do need to meet for the 99306, you do need to meet a 95-minute threshold. And for 99310, you do need to meet that 85. You do need to meet or exceed 15 minutes to bill for a unit of prolonged care. That prolonged care, that code that you're going to use here is going to be G0317. And I also want to call out, you're doing the work, you want to make sure that you're getting paid for it. I want to call out, it's not just time spent with that patient on the date that that initial or subsequent nursing facility code is being billed. You can count time from a day before that date of the visit and 3 days after. So make sure that you're accumulating all of that time. We'll see providers that'll bill, immediately after, on that date of service, but then in the next 3 days they have some additional time that they spent. I would recommend best practice is to wait until you're sure you're done with that encounter in those 3 days, just so that you have all of your time, because that additional time can make the difference in what you're being reimbursed. You might be missing out on some prolonged service units, and those prolonged service codes cannot be billed on their own. They have to be on that claim with that primary code, that initial or subsequent visit. So discharge management. This is the attending physician or someone that's acting on behalf of the attending physician that is providing discharge instructions to the patient. So these are going to be those discharge instructions for post-facility care. It is something that you want to identify the date and the time in which it happened. The date of service is going to be the date that the practitioner provided the service. Even if that patient is leaving the facility on a different date. So for example, let's say that the provider gave the instructions on Thursday and that patient did not leave the facility until, say, Friday. Maybe their home wasn't ready to accept them back. Some things needed to be set up. Even though that patient leaves on Friday, the discharge management occurred on Thursday in this scenario. So Thursday would be that date of service. A patient's only going to receive these services once. Okay, so if they're seen again, you see them on Thursday, they actually leave on Friday. If you see them again on Friday right before they leave, that's not an additional discharge management service. So you want to make sure that you're including the time that was spent on discharge management and make sure you're using the appropriate codes. Next is we're going to talk about pronouncement of death. For pronouncement of death, you are going to use the discharge management codes. Only one practitioner is going to be able to bill for this, and it's going to be the practitioner who actually pronounces the patient's death. So you want to make sure that if the pronouncement is made by the physician, it's being billed, but if it's being made by the nursing staff, you're not going to be billing for this service. So make sure that you're aware of that pronouncement. Again, documentation would need to support that. Split shared services are something that is available only in the SNF, but it goes back to how the facility classifies that patient. So they'd need to be in that Part A stay because that's considered that facility. Nursing facility is a facility, but you're not billing for those facility services. So remember, for split shared, the definition of a group is not the same as the definition that we use for, it's not necessarily tax ID. This is something that is determined by the group itself, usually through the form of an agreement or contracts. Those groups make those determinations. CMS is not making that determination, but you do need to have that documented. And in September, Ashley and I did do a series on split shared. So if you're looking for information on that piece, I encourage you to check that out. Split shared services, the billing practitioner is going to be the practitioner that provided the substantive portion of the service. CMS defines that as more than 50% of the total time or the substantive portion of the medical decision making. And when billing split share, the billing practitioner is going to need to use modifier FS to identify it as a split shared service. You can bill incident 2 for nursing facilities. So SNFs are going to do split shared nursing facility services. Again, that Part B stay are going to be eligible for incident 2 services if it's utilized. Documentation does need to show the plan of care, and that non-physician practitioner does need to be working under the plan of care from that billing practitioner. That billing practitioner can be an MD or DO, or it could be a non-physician practitioner. It just depends on the patient. But remember, the billing practitioner must be in the facility and able to provide that immediate assistance in case there's any changes or adjustments that need to be made. Services in an office facility. There are going to be situations where the practitioner has a specific designated office space inside that facility. It's not super common, but it does happen. This is a space that is their office and it's not technically part of the facility. It might be in the same building. Any services that are provided in that office are going to be billed with the office place of service. So it's going to be that 11, and they're going to use office procedure codes. However, you step out of that office and services are starting to be provided outside of that designated area. Now at that point, you are in the realm of you need to use the 31 or the 32, whichever is appropriate. If you are outside and you have ancillary staff that are providing services outside of your designated space and they're in that skilled nursing facility setting, they're in that nursing facility setting, those aren't going to be billed because those are part of that facility service. Telehealth consultations. So as you're probably all very aware, Medicare does not pay for consultations. You're billing regular E&M codes. However, there is an exception for telehealth consultations, and Medicare will allow them for SNFs and nursing facility patients. So the provider that is furnishing the consultation via telehealth cannot be the physician of record or that attending physician. So this is going to be someone who's providing distinct care from what's being provided, okay? These are the codes you're going to use, the G0425 through 427 for the initial consultations, and the subsequent is going to be the G0406 through 408. You do need to make sure that that request, the feedback that you receive is part of that medical record so that we know that this was that telehealth consult. We are also going to make sure that need to make sure that these are billed with a place of service too, because they are telehealth. Now, telehealth is something that is a little bit of a hot topic. There are flexibilities that were allowed to expire on October 1st. Okay, so telehealth is appropriate for inpatient services, and that does include nursing services and those discharge management services. Again, that place of service is going to be 2. Frequency limitations were waived through 12/31 of 2025, so we're going to have to watch that 2026 final rule, see if that's going to be made permanent. And also because we know there's a lot of questions about telehealth right now, there is an FAQ that I've provided a link here that talks about telehealth for the remainder of this year, now that those flexibilities have been allowed to expire. Those flexibilities, barring congressional or CMS action, have not been extended. If that were to occur, we'll certainly offer that education. So I encourage you to check out that FAQ because that does really do a nice job of covering the where we are now. Also, about a month or so ago, would have been in October, so about a month ago, uh, one of our colleagues did a really nice telehealth presentation that is telehealth past, present, and future. That's available on our Encore page right now. That will be very beneficial if you have questions about telehealth in general. So we're going to go ahead and wrap up. I know we're running a little long. I want to make sure I'm respectful of everyone's time, and I appreciate you sticking there with us. Here I have included some resources. I mentioned that CFR, and I've also included some IOM references or manual references that go deeper into the items that we've talked about today. And here I also have included a link to CMS's Skilled Nursing Facility Center that goes into a lot on billing if you're actually billing for that skilled nursing facility, along with our Evaluation and Management Services MLN article. That has a lot of great information about prolonged care and including some examples. And then we have a resource that is specific to that certification and recertification, those guidelines there. That's a good resource if you have questions on that. So I know there's a question in the chat, but again, I want to be respectful of people's time. So I am going to go ahead and I'm going to answer that question in a follow-up document, but we will absolutely make sure you get an answer to that question. I will be taking additional follow-up questions if you have them for the next 7 days. Ashley's just put some information in the chat. You're going to send that to our education mailbox, and I will be sure that Ashley and I get responses to those questions to you. So certainly, we didn't get to live questions today. I apologize for that because of time, but we are certainly going to answer those questions, and I will send all questions that we get to everybody on the call today. So with that, as I said in the beginning, you are going to have an opportunity to provide us with some feedback. In a few minutes, you're going to get an email that's thanking you for attending. Don't delete that without taking a look at that. That serves 2 things. Not only can you take our survey through that link, that is also your certificate of achievement if you're attending today for continuing education credits. If you didn't get it, one of 2 things happened. Either you attended by phone and I can't verify your attendance, or maybe something got caught in your firewall or your junk or your spam filter. If you send an email with the title of today's session that includes the phone number from which you attended, I can confirm your attendance and I can get that certificate of achievement out to you. As I said, also, you're going to have that opportunity to provide us with a survey. I did want to point out that I am showing you an image. It's got that little yellow triangle on it. That is a redirect that you're going to get when you leave this session. That is not spam. That is not malicious. It is not taking you anywhere that you don't want to go. It's just another way to access our survey to provide us with a little bit of feedback. And it's just telling you you're leaving our webinar software and going into the Qualtrics survey software. With that, that ends the session for today. On behalf of myself, Ashley, and the entire Provider Outreach and Education team, I'd like to thank you all for taking the time to join us today. I know we ran a little long, and I do appreciate your time. I know we're all super busy, especially this time of year. So everybody, that concludes our session for today. I hope you have a great rest of your week, and we hope to see you in future educational sessions. You may now disconnect.